We're going to be recording. So this is a special ALKtALK for me because I've invited my doctor to come in, and hopefully he doesn't bounce off the Zoom, knowing that he's talking to all of us. But a couple features on our ALKtALK, which for Zoom, and that's please mute on the bottom left-hand side if you're on a computer or your phone. Also on the screen on the top right, view. You can view the speaker, or you can go ahead and review. Please mute, Nancy. You can view on the speaker, or you can view in the group setting. The other thing too is we have an incredible YouTube videos that, hold on, you guys want to, I'm going to pause for 1 second as everyone is muting. Gina, can you mute some people? Thanks. All right. Anyways, there's incredible ALKtALK videos that are on our YouTube channel. If you have not checked them out, you can get caught up on some remarkable doctors that we've spoken to. And also on Sunday, on this week, I think we have like 7 different activities that you should check our calendar. So, and I'm going to go ahead and throw it off to Gina. Gina, do you want to talk a little about our fundraising?
Sure. We're doing our end of the year fundraising push. And we know that one of the things is that the more we raise, the more research we can fund. And so we've done an incredible job. We were hoping to raise $1 million by December 31st. And we did it well before then. After our December 5th push, we raised over $1 million. So I'm so excited about that. But those of you who know how much actual research costs to get it to the bedside, you'll know that it's way more than $1 million. Sometimes research can cost several $1 million. So it's really important that if we really want to get the best research that can get us stuff to our bedside and stuff that will benefit us now, we do have to raise a lot of money. So I wanted to spotlight some of these great fundraisers who know that more research means more life. Team George was formed by his family, and they were just really, he was diagnosed at 48, and they really just wanted everybody to know that anyone with lungs can get lung cancer. It's not always about how much you raise, but really about the opportunity to put the story out there and to let people know about what is ALK positive cancer. Manera Arabi, this was her first time to fundraise, and she's doing an absolutely incredible job. And then our very own Dana, check out the name of her lung cancer fundraiser, Help Dana Live Longer. She's already raised 262% of her goal, and so she's done a great job. And we know that all of us working together, that's how we're really able to do the best work. So I'll hand it back over to Mark as everybody is coming in. And I just wanted to tell everybody, thank you so much for your incredible efforts. We've already been able to raise enough money to fund 2 clinical trials and over 5 translational research projects. So we just need to keep on working together to make sure that we can really push research for ALK positive cancer patients. Thanks.
Okay, as usual, we start these meetings typically with polling questions. So I'm going to launch the first question. What's your length of your diagnosis? This does not show up on a recording, so I'm going to be speaking out loud on the results. And like I said, please mute if you have not muted yet. Okay, I'm going to end the poll, and I'm going to show you the results. So we have 39% of you are 1 to 2 years, 1 and under at 21%, 3 and 4 years are 23%, and then 5 to 6 is 7%, 7 to 8 is 4%, and more than 8 years is 5%, which is amazing. And I'm going to go to our next poll, which is going to be I'll launch this. When you have progression, where in your body have you had progression? If you have no progression, you can answer there too. Come in the poll, share the results. And this makes sense. 44% of us have not had any progression. If you've had progression, 24% is in the brain, 23% is in the lung, and then 15% are in the lymph nodes. And then we have a bunch of other ones. So I'm going to end that poll. And then, excuse me, I'm going to go to the next poll, which is what type of drug treatment are you taking? So what current, how many TKs have you taken? And that's including chemotherapy. If you've taken chemo or immunotherapy, which probably not many of us have taken. Okay, I'm gonna end this poll, share the results. So we got 59% of us have taken one TKI, and then 2 TKIs are 21%, 50% are 3 TKIs, 19% of us have had chemotherapy. Stop sharing, and then this is the last question. What is your medication that you're currently taking?
Mark, I'm taking 2. How do I do that?
Well, since you're talking to Ellen, you can tell us what you're taking. Lorlatinib and chemotherapy, correct? All right, I'm gonna end this poll. Sorry. Alectinib is 1%. I mean, excuse me, 53%. Lorlatinib is 22%. Brigatinib is 7%, and then chemotherapy is 6%. I know some of you are taking combination. Well, there you go. You can see it now. I know some of you are taking combination, and I'll adjust that next time. So we're going to kick this off. And Ellen, can you stop your video? Oh, that's interesting. There we go. Are you guys seeing me or no?
Yes.
Oh, you are seeing me. That's interesting. Okay. So Dr. Gadgeel and I have known each other for about 6.5 years. Very quickly, I just want to say that Dr. Gadgeel back in 2016 basically saved my life. I got turned down for having brain surgery from a large institution, and he was my second opinion doctor, fought for me, and I ended up having brain surgery in 2016. So I want to thank you, Dr. Gadgeel, or I don't think I would be talking to you in 2021, but here we are together. So I want to introduce him by saying that he started out at, he's over 20 years in practice. He started at Carmanos Cancer Institute. He was the director of thoracic oncology. He went to University of Michigan. He was a professor in thoracic oncology. And then he's currently working at Henry Ford Hospital, running the hematology oncology division at Henry Ford Cancer Institute, which is where I'm currently seeing you. So welcome. That was a mouthful.
And thank you. Thank you very much.
I'm going to briefly just want to say hello and just let you start talking, but what is an ALK expert? You get
what is an ALK expert?
Yeah.
For me, ALK expert is a physician who has the privilege of knowing some wonderful, phenomenal patients. I see on the video some of my patients, and I can tell you my first thought was, gosh, it is so lovely to see some of my patients without masks. Some of you who have seen for many years, I don't think I've ever seen, I have not seen you without mask. And some of the patients actually I'm seeing for the first time because I've seen them since COVID started. So Thank you. It's truly a privilege. I will tell you, I don't consider myself an ALK expert. I consider myself a lung cancer doctor who has had the privilege of taking care of some ALK patients. And to be very honest with you, I have learned a lot more from the patients than I think what I have taught or I have conveyed to the patients. So I am a fortunate person. And what I wanted to do today is sort of go over what I think ALK patients may want to know. Hopefully that covers some of your questions, but I would be happy to answer. I lead a very boring life, so I don't have much to do after 8 p.m. today. And so if I don't mind staying on if there was any interest. So I am going to share my slides. And before I share my slides, I do want to mention that I am finishing up with a case story of a patient of mine. I see that patient today, and I sincerely hope that it's okay for me to go over that patient's story, because I think, to me, that that patient's story is a story of hope. So I just wanted to start off with what is the perspective that we lung cancer doctors have. Hopefully you can see my slides. Can you see my slides? No? Hold on one second. Can you see my slides now?
Yeah,
Okay.
we can see them.
Sorry about that. So I'm starting off with survival curves of a clinical trial for stage 4 lung cancer that was reported in 2002. I started my career in 2000. And I'm only mentioning this because I want to give you a sense of where we doctors are coming from. And I say this because I've sort of talked to some patients, and patients are not satisfied, and appropriately so, with the advances we've made. So sometimes patients are surprised that we are excited about things that may not seem all that exciting to the patients. And the reason is because this is where we started. First of all, we only knew non-small cell lung cancer and small cell lung cancer. We knew about adenocarcinoma and squamous cell carcinoma, but that didn't make a difference in the treatments we chose. And in late 1990s, there were new chemotherapy drugs introduced that were not necessarily better than the older chemotherapy drugs, but they were better tolerated, and therefore patients could get better benefit out of them. And there was a lot of excitement about these drugs. But unfortunately, when this 1,100 patient study was conducted in the United States across multiple cooperative groups, what this showed is they looked at 4 different what is called as platinum-based chemotherapy regimens. And the outcomes were very, very modest, at, if that's a sort of politically correct term to use. And that was the 1-year survival. Sorry. At 1-year survival at 4% and 2-year survival of 12%. And so the only reason I bring this up is, please understand that when we see patients surviving, stage 4 patients surviving for 5 years, 6 years, that by no means we are satisfied by those outcomes. But for us, it's a huge progress from the point where we started managing lung cancer patients. So of course, one of the major changes that has occurred, sorry, I'm unable to move my slides. Hold on. One of the major advances has occurred is identifying what are called as driver genetic alterations. And based on that, there are drugs that are developed that target those alterations. You all know this very well. The first alteration that was targeted was EGFR, and the second was ALK. Of course, the other major advance is immunotherapy, and I will talk to you about that as well. Now, ALK is very unique, as all of you know very well, but I do want to mention this, and that is that the median age of lung cancer patients is about 70 years. The median age of ALK patients and ROS1 patients is 50 to 55. We don't know why it's a younger age group. Majority, over 70%, are never smokers, and even the ones who have smoked to a very limited extent. So why these young never smokers develop this disease, we don't know very well. What is another important point to remember is that the percentage of ALK patients across the world is about the same. That is, EGFR patients EGFR mutation positive lung cancer occurs quite commonly or at a much higher percentage in East Asian countries. Whereas when it comes to ALK, the percentage is about the same. The only reason I'm sort of mentioning this is that I believe that there may be some hints as to why this disease develops. But we have known this for some time, and at least as of now, that information has not led to us being able to figure out why lung cancer develops in these patients. But my suspicion is the fact that it is the same across the globe. It's a younger population, and over 70% of the patients are never smokers, may lead us to identifying why this cancer develops. So this is a picture from the paper that was led to the identification of ALK translocation as a driver genetic alteration in a proportion of non-small cell lung cancer, specifically adenocarcinoma. And this was quite, it created a lot of buzz in the medical circles. In 2007, a Japanese group identified that there can be a translocation in the genes of EML4 ALK. We know now subsequently that ALK can have other genes as partner genes in that fusion protein. But EML4 ALK is approximately 85 to 90%, about 85% of ALK patients are EML4 ALK. So what does that mean? So EML4 is a gene and ALK is a gene, and basically a portion of the EML4 gene translocates and comes and binds to a portion of the ALK gene. What is interesting is both these genes are on chromosome 2, and basically they are kind of on top of each other, a little separated. And for reasons we don't know, a portion of the EML4 gene comes and sits in the middle of the ALK gene. And that results in a new protein, the EML4 ALK protein. And this EML4 ALK, in effect, leads to the ALK protein being hyperactive. That EML4 ALK gene being together leads to a protein being formed from EML4 ALK that leads to the ALK being hyperactive. Genes at the end are a code for several cellular proteins, and it's these proteins that dictate cellular function. And so if the ALK protein is hyperfunctioning, what that causes is it causes the cells to divide and proliferate. And it also gives them the ability to detach from where they are located, get into the blood vessels, and travel to other parts of the body. And what they did is they inserted this EML4 ALK gene. So what they showed is they took a look at these mouse models. And if you put the EML4 gene by itself, nothing happens. If you put the ALK gene, nothing happens. But if you put this fusion gene, where there's a portion of EML4 and a portion of ALK gene, it causes these tumors. And if you gave an ALK inhibitor, if you gave a different fusion, nothing happens. And if you gave an ALK inhibitor, these tumors shrink. There's one other thing that they discussed, and that is the amount of EML4 gene that then binds to ALK gene. So when you look at the EML4 ALK, this new gene that has now been formed, the ALK portion is the same in every patient. The EML4 portion varies, and depending upon how much of the EML4 gene has bound to the ALK gene, that dictates whether it's variant 1, variant 2, variant 3. And as you know, so this shows variant 1. Variant 1 is more common. And there's some data to suggest that the response to treatment may be different depending upon whether a patient has variant 1 or a variant 3 and so on and so forth. But I must say that at the present time, in my opinion, the data is not robust enough to dictate treatment decisions based on what the variant is. It is quite possible, though, that that information may become relevant in the future. So it so happened that around the time this paper was published, I believe this paper was published in August of 2007, Pfizer was developing a drug called CRizzotnib that actually was being developed for something called as MET blockade. There is another substance called MET that can drive some cancers, including some lung cancers. And CRizzotnib was being developed as a MET inhibitor. But when this paper was published, they started testing lung cancer patients for ALK because they knew MET, the CRizzotnib rather, in addition to MET, could inhibit ALK as well. And I give tremendous credit to folks like Alice Shaw and Ross Camage, who were doing, and Dr. Ignatius Wu, who were doing the phase 1 trial of CRizzotnib in 2007. And when this paper came out, working with the pathologists, developed a test that could identify this ALK translocation in lung cancer patients. And they then, based on, enrolled those patients on this trial, phase 1 trial, and found very dramatic benefits. And to me, this patient story really conveyed what is possible in lung cancer. Mind you, before this, we were only using chemotherapy and different chemotherapies, and the outcome I told you. And the only other targeted agent we had before this was the EGFR drugs. And so this was a 52-year-old patient, actually an Iraq war veteran, a never smoker, who was diagnosed in around January of 2009, had gone through multiple different chemotherapies, including an EGFR inhibitor, because at that time we were using EGFR inhibitors even in patients who didn't have EGFR mutation. And he came on 3 liters of oxygen in a wheelchair when I first saw him in February of 2020. And we sent off his tumor for ALK testing. The result came out. That time, we had to send the tissue to Pfizer because Pfizer was only doing the testing. And the results came back positive, and we started him on the drug. And I cannot tell you what it what it meant to me as a doctor to see this patient who had come on 3 liters of oxygen in a wheelchair, and 2 weeks after starting the drug came walking in. He still had oxygen, but he was only using oxygen on exertion. And then 3 months later, this is a scan, and you don't have to be a radiologist to know that this is a dramatic improvement. Now, unfortunately, the patient about a year and a half later passed away. But nonetheless, to me, this truly conveyed the promise of what we call now targeted therapy, that if you identify what is driving the cancer, and we are not able to do so in every cancer patient's cancer, that if you have a drug that can block that main driver, that you can shrink the cancer. But there were some limitations to CRizzotnib. One is it was not as potent an ALK drug. And in addition, it inhibited other proteins such as MET, and that did cause side effects. And so the amount of drug one could give of CRizzotnib was somewhat limited. And the other thing is it didn't appear to cross the blood-brain barrier very effectively. So there was a big need to develop other drugs that could inhibit ALK better and cross the blood-brain barrier. And one such drug that I had the privilege of working with was alectinib. And just walking you through this slide, if you look at the figures on your right, I don't know if you can see my arrow, but it shows the spectrum of proteins that alectinib inhibited and that CRizzotnib inhibited. And the blue bar represents how effectively the alectinib benefited. So you can see the blue bar with alectinib is longer than the blue bar with CRizzotnib, and that suggests that alectinib is a more potent ALK inhibitor. But as you can see in the rest of the figure, it didn't inhibit any of the other proteins. And so it led to the possibility that if you gave alectinib at a dose that could effectively inhibit ALK, that you're not going to see the side effects of inhibiting some of the other proteins that crizzotnib inhibits. And there were preclinical models that showed it could cross the blood-brain barrier. And I had the immense fortune, so that this drug was first developed in Japan. And so actually alectinib was, I believe, first approved in Japan even before crizzotnib was approved. But then subsequently, alectinib phase 1 study was started in the United States in around May or June of 2012. And I had the privilege of treating the first patient on alectinib outside of Japan. This, what is called as waterfall plot, represents the extent of tumor shrinkage. And what was significant to us at that time is these were all patients who had already been treated with crizzotnib with chemotherapy, and to see now shrinkage in the tumors was quite dramatic. This phase 1 study was then subsequently a phase 2 study was conducted in many more institutions, and it confirmed the benefits of alectinib in patients who had previously been treated with crizzotnib, and subsequently led to this randomized phase 3 study of alectinib versus crizzotnib as first-line treatment. So once they found that alectinib worked in patients after crizzotnib, the next logical step was to look at whether alectinib was better than crizzotnib. Now, a couple of important things to remember about this study. One is that the ALK was tested by Genentech Roche centrally, and the test utilized was immunohistochemistry. And at the end, I may go into the details of testing. We now do mainly NGS, which I think is a better test than the IHC. These were all advanced ALK positive lung cancer patients. And an important aspect of these studies, there were two important sort of novelties about this study. One is, for the first time in lung cancer trials, patients who had brain metastases, but they were asymptomatic from brain metastases, were allowed on the trial. And the reason this is a novelty is, before that, we did not trust our systemic treatments to treat brain metastases. And so patients who had brain metastases had to have received either surgery or radiation or both before they were eligible for the trial. So this was definitely a drastic difference in this trial compared to previous trials. And the other novelties, this was the first trial in lung cancer that compared one targeted therapy to another targeted therapy without the previous standard of platinum-based chemotherapy. Now, this is of no great it won't garner any great attention, but I cannot tell you how amazing it was for somebody who by then had been doing lung cancer for 14 years, and the first treatment was to give IV chemotherapy, to now randomize patients to one pill or the other. And so this was truly something quite dramatic. So these are the updated results of this trial. And one thing to note is this is progression-free survival. That is, what is after you start on the treatment, when did the doctor who was treating the patient determine that the cancer is outgrowing alectinib? And the average was about 35 months, or approximately 3 years. But look at the beginning of the curve. There are patients who start progressing right away. And then there are patients who are going on for almost 5 years, or almost 4 years rather. And as yet, we still don't have a good handle on who are the patients in this part of the curve and who are the patients who are in the who have not progressed for 4 years. Another important concept I wanted to convey is one of the efficacy parameters that we tend to look at is something called as hazard ratio. Hazard ratio here was 0.43. What does that mean? When you look at the median, that is one time point along the curve, and that conveys some indication of benefit. And that, by the way, that median was 11 months with crizotinib. So it was far less. This was almost tripling of the median. But median nonetheless is one time point along that curve and may not be truly reflective of the exact benefit from the drug. And what hazard ratio means, and I hope I'm able to make this simple enough so that I can convey this, and I can go into this a bit later on if required. But what the hazard ratio means is that every point along this curve, the probability of a patient who is on crizotinib, patient who is on alectinib, has about a 67% less chance of progressing as compared to a patient who is receiving crizotinib. And whether it's this time point, this time point, this time point, when you look at these, when you average that out, at every point along the curve, a patient who received alectinib had a 67% less chance of his or her cancer progressing as compared to the patient who was receiving crizotinib. And there's a reason I wanted to convey this concept, and I'll come to it when I discuss the lorlatinib data. And the 5-year survival. Now, this is survival. Sorry, this is still event-free. This is survival rather. This is not progression-free survival. So the 5-year survival in this study was 62%, and the 5-year survival with crizotinib was 45%. Now, this didn't meet the statistical criteria of significance. So there was a 17% difference in survival, but I want to emphasize this was not statistically significant. Nonetheless, clearly the trend was towards alectinib, patients who were on alectinib having a better survival as compared to patients who were on crizotinib. And one of the major reasons that it is felt that alectinib was better, yes, it's a better ALK inhibitor, but one of the major reasons it is speculated that alectinib was better was because of its brain activity. I just wanted to mention this patient of mine. To me, I'm trying to convey this was a journey. This was a journey with patients that still means a lot to me at a very personal level. So this was a patient who was 44 years old when she was diagnosed. She was diagnosed when she developed a seizure while attending a soccer game that her daughter was playing in. And at diagnosis, she had brain mets, and she received SRS. She initially started on chemotherapy. This was back in 2012. And about 8 months after receiving chemotherapy, she was found to have ALK positive disease and was started on crizotinib. She required SRS to the brain almost 3 times. She had heard about trials when she had her 3rd progression, but she lived in a state other than Michigan where I am, and she did not want to travel because she knew that her time was limited and she didn't want to spend time away from her daughters. But what happened in somewhere around 2014, I believe somewhere around May or June of 2014, is that she was found to have what is called as leptomeningeal disease. So this is, leptomeninges are the covering around the brain. Think of a saran wrap covering a sandwich. There's a saran wrap that covers, not a saran wrap, but saran-like wrap-like thing that covers the brain. And these are very refractory to different treatments. So this is her scans before she went on our trial. Went on the trial that we had open at Karmanos when I was there. The radiation doctors were unwilling to radiate her because she had already received quite a bit of radiation before. And it was at that point she agreed to come to our center for the trial. This is her scan 6 weeks later. By the way, she did not have any symptoms related to these leptomeningeal metastases. But this was a scan 6 weeks later. It was almost complete resolution of her leptomeningeal disease. Now, about 20 months after she started on the trial, the patient passed away. But at some level, as a lung cancer doctor, there was some satisfaction, and I hope I can convey this feeling properly, that she did not suffer from the symptoms of leptomeningeal disease, because sometimes leptomeningeal disease can cause quite significant symptoms. And so 20 months later, she passed away, but there was some satisfaction in that she did not suffer from the leptomeningeal metastases. And this was then, because of these observations in the phase 1 trial, they included patients with asymptomatic brain metastases. But I wanted to show you this data from the ALK trial that looked at patients who did not have brain metastases. Kindly look at the right side curve. So these were patients who did not have brain metastases, and they were followed with scans, even if they didn't have brain metastases, with brain MRI. And if you look at crizotinib, by 12 months, almost a third of the patients had developed brain metastases, whereas that rate was about 5% in patients who received alectinib. And what that tells you is there are patients who don't have brain metastases detected on scans, but the cancer has spread to the brain, but the size of those lesions is less than what can be detected on the scans. And so those lesions are not effectively treated by crizotinib, or not as effectively treated in all patients, but in a good proportion of those patients, alectinib was able to treat them, and therefore those brain mets did not progress. Now, I do want to mention, before I talk about lorlatinib, is that brigatinib has similar data. For time's sake, I did not include brigatinib, and I also did not include brigatinib data because I did not participate in the brigatinib trials. But brigatinib has a phenomenal data. It is as good as the alectinib data. And please don't take this that I'm not discussing the brigatinib data in any way that it is any different than brigatinib. But after the data of alectinib and brigatinib and ensartinib and all of these drugs were tested in trials similar to the ALK trial compared to crizotinib, and the hazard ratio, which I hope I conveyed the concept, was almost identical in each of these trials. That is, the benefit compared to crizotinib was better, but it was better to the same magnitude in each of those trials, suggesting at that point, my feeling was that's the ceiling we have reached. We are not going to see any greater improvement as first-line ALK treatment. As you know, around the time that alectinib was being tested in the frontline setting, lorlatinib was being tested in patients who had not only received crizotinib, but also drugs like alectinib or ceritinib or brigatinib. And it had shown very promising results. And so lorlatinib was then tested. Unfortunately, by the time lorlatinib was tested in this CROWN trial against crizotinib, alectinib was already approved as first-line therapy, and therefore we did not participate in this trial. But I will be very frank with you and say, I expected, the lorlatinib results are going to be the same because every ALK trial till that date had shown the same benefit. But when these results were first presented in 2020, I was quite impressed and surprised that the lorlatinib provided a greater magnitude of benefit as reflected by this hazard ratio of 0.28. Just to remind you, the hazard ratio with in the ALK trial was 0.43. This is 0.28, suggesting that at every point along the curve, there was an 72% less chance of progression on lorlatinib. This was clearly superior to what is seen with alectinib or brigatinib in this trial. Now, scientifically, we are not supposed to compare the results of one trial to the other. These are independent trials, and some of the results can be just by chance. Nonetheless, it is very difficult to get away from that hazard ratio of 0.28. And its CNS activity was just quite impressive. However, lorlatinib does have side effects that are somewhat unique. There's the issue of cognitive effects. There is the issue of peripheral neuropathy. It causes hypercholesterolemia. It causes edema. It causes increased weight. And it can be challenging for some patients to tolerate the drug, leading at least a discussion among physicians who manage ALK patients as to whether every patient really, yes, the data looks to be better with lorlatinib as first-line therapy, but do we really have to subject patients to some of these side effects, which we don't see with other drugs? And how can we be somewhat judicious in utilizing the drugs? And so this is my take. Kindly note, we are still in the phase where we are still trying to figure out what is good. I will say that in most patients, I still use alectinib as the frontline treatment. However, if a patient has a lot of metastases, there's some patients who present with liver metastases and bone metastases, and in particular, multiple brain metastases. And if I have that sort of a patient, I'm likely to choose lorlatinib. So I would say this is my practice. I'm not saying that's the perfect practice. You go to some other folks and you've had some brilliant physicians already, and I'm sure that they may have addressed this issue. And some folks feel very strongly about one drug or the other. In my opinion, I feel I should have a discussion with the patient, go over the issue, the clinical scenario that that patient is facing, and then choose. Because I don't know that every patient needs lorlatinib. Because as we saw in the ALEX trial, there are definitely some patients who do quite well on alectinib. And alectinib in general, and there are patients who have challenges with alectinib, but in general, patients do well. And so one needs to be just judicious. Very briefly, how do we go forward? Generally now, when the patient progresses on first-line ALK drug, we try to rebiopsy or send a liquid biopsy and try to figure out if the patient has an ALK-dependent resistance mechanism, that is, has the cancer outgrown that medication because some alteration, further alteration has occurred in that ALK translocation. And if that is the case, there is a preference to lorlatinib. If it is not ALK mutation dependent, I had a recent patient who 6 months after starting on alectinib developed progression. We biopsied his tumor and he had c-Met amplification. So we did switch him to lorlatinib for a variety of reasons, but also added a c-Met drug called capmatinib. I could have continued him on alectinib and added the MET inhibitor. If we don't find any mutation, one could still use lorlatinib, but one could also consider chemotherapy. Now, I do want to mention, in my experience, whenever I have raised the possibility of chemotherapy, it has really disappointed patients because the perception as I see it is people view chemotherapy as the last resort and view that there is nothing beyond that. And I don't think that is true. There is a role for chemotherapy, and more now, we are not switching to chemotherapy, but adding it to lorlatinib or some other ALK drug. And I can tell you that I have some patients, not all, but some patients who have done very well, particularly on pemetrexed or Alimta for a very long period of time. And so one message that I do want to convey is don't view chemotherapy as the last straw. Some patients can do quite well, and many patients do well on chemotherapy. Yes, it has side effects, but everything has side effects, and they can be managed in many patients. So important to note. Finally, there is immunotherapy, but the currently immunotherapy drugs have not been very effective with ALK. One thing I want to say is immunotherapy is a broad term. When we say immunotherapy is not effective, we are really mentioning that the currently available immunotherapy drugs are not effective. I do expect that eventually other immunotherapy drugs will be beneficial in ALK. Sorry, I've gone too long, but I just want to quickly finish Liquid biopsy is playing a bigger role. We now many times detect at diagnosis the genetic alteration like ALK in the blood. And we have now done clinical trials that show that even if it has been detected just based on blood, the benefits with alectinib are, or any of the ALK drugs, sorry, this is data from an alectinib trial that tested alectinib in patients where the ALK was detected just based on the blood test. No tissue test result was available. And alectinib provided same benefit, in fact, maybe a little bit better benefit. But one of the advantages of the NGS test that we can do either on tissue or in the blood is that we can learn something more than just whether the patient has ALK. We also know whether the patient has another, what is called as a co-mutation in something called as P53. And there's data to suggest that patients who have a co-mutation in P53 may have a slightly worse outcome than the patients who don't have P53. And it is quite possible that in the future, we may use these markers to decide, that these patients should not just be treated with ALK inhibitor, but maybe we combine it with something else so that these patients will do well as the patients who don't have P53 mutation. And this is the similar story with variant 3, that there is some data to suggest that variant 3 patients may not do as well. And that can also be identified on NGS testing. And therefore, NGS testing provides us more information that even though right now may not impact treatment decisions, may impact in the future. In addition, as I told you, that once patient progresses on an ALK inhibitor, we try to define the mechanism of resistance, and liquid biopsy can be very beneficial in that. And this is data about lorlatinib in patients who had already been treated with drugs such as crizotinib and alectinib. And what was found was that there was benefit seen in both groups, but in patients who had an ALK-detected resistance mechanism, ALK-dependent resistance mechanism rather, lorlatinib patients did better. Patients treated with lorlatinib did better as opposed to patients where an ALK-dependent resistance mechanism was not identified. Now, I want to be very careful in saying, even if ALK-dependent resistance mechanism is not detected, lorlatinib can have a role. I don't want to, but it does appear that the benefit is somewhat better. And then finally, going back to the CROWN results, talking about the liquid biopsy again, it is maybe possible that we may be able to identify patients who are going to not have such a good course early on. And this is what they did was, in the CROWN trial, they collected blood at baseline, and then they also collected it at certain specific time points, 6 weeks, 12 weeks, and 24 weeks. And what they found was that in general, patients who did not have ALK detected in the blood at baseline did the best. But then if you had ALK detected at baseline, if the ALK cleared out or reduced to a very low level in the subsequent samples after the patient was started on lorlatinib, those patients also did well. And if the ALK did not decline very well, then those patients may not do as well. Now, I want to be very careful. I'm just presenting this data to you as something that we may be doing in the future. This is not ready for prime time, but interesting data that we may be able to not just wait for the progression to occur, but may get proactive and try and identify who are the patients who are likely to progress and use that data to decide whether we need to do any further therapy. So again, interesting roles for liquid biopsy at diagnosis, at resistance. And then when they have started on first-line therapy, maybe sequential samples may allow us to define which patients are going to do well and which not. Immunotherapy doesn't work very well. I don't necessarily have to go over this. We recently did a clinical trial of chemotherapy and immunotherapy. It included both EGFR and ALK patients, and only 7 patients. The trial had a lot of issues, not to mention COVID. Only 7 patients were enrolled, so one needs to view this data with a lot of caution. But it appeared that chemotherapy and immunotherapy did not work as well in ALK patients as EGFR patients. This was not designed to compare the two groups, but just looking at the raw numbers, it appears the case. In general, when I start on chemotherapy, I generally add chemotherapy to an ALK drug. And there are issues with combining currently available immunotherapy drugs with the TKIs. There could be toxicities when we combine. And so in most patients, I'm not using chemoimmunotherapy. So what is coming, this is just a small sample size. There are now what are called as fourth generation. So CRizzotnib was considered first generation, alectinib and brigatinib second generation, lorlatinib third generation. There are fourth generation ALK inhibitors that are, one of them already is in clinical trials. There's another one that is going to be started next year. And there are two aspects of these drugs that are interesting. One is that they are even more potent inhibitors. But more importantly, what is happening is that when you treat patients with drugs like alectinib or lorlatinib, when the cancer progresses, it develops double mutations. So it may develop two ALK mutations that makes it difficult for the currently available ALK inhibitors to overcome. And these fourth generation ALK inhibitors were developed to overcome double ALK mutation resistance. And that's why they may land up being beneficial. However, we are in very early days and difficult to know how well this will pan out. There are a lot of combination treatments that are being looked at. Mr. Rosenzweig mentioned about SHEP2 in a document he sent me ahead of this. He prepped me. He needed to prep me for this talk. So he mentioned about SHEP2, and I can talk about that. I also want to mention there's an interest about combining chemotherapy is first-line therapy with an ALK inhibitor. This is already being done in EGFR. Folks have not felt comfortable pulling the trigger. But my suspicion is that that will be tested. And then the next important thing, as I already mentioned, is trying to be, how can we be smart and identify who are the patients where alectinib might be perfectly fine, who are the patients who need lorlatinib, or who are the patients who need a combination, or who are the patients maybe in the future that we are going to start a fourth generation inhibitor. We are learning more and more beyond ALK translocation of that cancer, such as P53 mutation, such as variant 3, such as changes in the ctDNA that can guide us. The other drugs, this is not ALK specific, but this is across lung cancer trials, something called as antibody-drug conjugate. And I'm going to do my best using this figure to convey the concept of what is antibody-drug conjugates. We all know about antibodies. Antibodies that we produce or produce in response to vaccines bind to specific proteins. So a particular antibody can only bind to a particular protein. Cancers on their cell surface express proteins that are unique and are not expressed to the same level in normal tissues. And so there has been an interest in developing antibodies against proteins that are selectively expressed on cancers, but not expressed on normal tissue. And then what they do is they use a drug linker, this small line that you may be hopefully able to see. And using that drug linker, they tag along chemotherapy with the antibody. So one of the antibodies I know that has created interest, one of the drugs that has created interest is DS1062, which is against TROP2. So TROP2 is expressed far more commonly on lung cancers than normal tissues. And so the idea is that the antibody is only binds to TROP2. And then that is, with it, there are linker that is attached to the antibody. And then to the linker is attached chemotherapy. In this particular example, you can see there are 8 molecules attached to one monoclonal antibody that binds to TROP2. So what happens is when you give this drug IV, the drug floats around in the circulation. When the chemotherapy is bound with the linker to the antibody, the chemotherapy cannot work. The chemotherapy is bound and there is no effect. Once the antibody binds to the TROP2 the whole antibody gets internalized into the cancer cell, and then the linker is broken up and the chemotherapy is released. So it is basically delivering chemotherapy selectively to the cancer, utilizing the fact that there are these proteins that are present on the cancer cells at a much higher level than normal tissue, or they're not even present on normal tissue. And that selectivity is utilized to deliver a high amount of chemotherapy. You're literally like dropping a bomb in the cancer. So remember, you can deliver now 8 molecules of chemotherapy. If you gave that just IV, you would kill the patient because it would kill normal tissues also. So now with one monoclonal antibody, and there are several in the infusion that you give, you can deliver 8 chemotherapy molecules to the cancer cell. I hope I've been able to convey.
Can we stop at that point for a second and take a breather?
Okay.
Jeff's still with us, I hope, because I can't see everyone on the screen. Jeff is part of our clinical trials committee, and we want to talk about the antibody drug conjugates.
Okay.
And talk about this trial that you actually have at Henry Ford. So Jeff, take it away.
Hi, Doctor. Thanks for joining us. Appreciate it very much. So I am on the clinical trials committee. I'm by no means the head of the committee, Mark. So what we're doing is watching all the clinical trials very, very carefully, and sometimes talking with the drug companies to modify the trials themselves, to try to get ahead of the trials so that we can help them design, etc. One of the trials we're looking at is Daiichi Sankyo's TROP2 antibody drug conjugate. We're watching that very carefully because a lot of us are on lorlatinib, including myself and Mark certainly. And we're all watching very carefully to see what comes up next. So the ADCs have gotten a lot of press and a lot of attention. And this is one that is specifically designed, as we understand it, for oncogene-driven lung cancers, including ALK. Did I get all that right?
Absolutely.
Okay, so you've explained for us what an antibody drug conjugate is, but when would a patient want to do this particular trial?
So one of the questions that had been put by Mr. Rosenzweig in the document he sent was that, why should I have received chemotherapy before going on this trial? And that is simply because chemotherapy has an established activity in this patient population with I would say a substantial minority, if I can say that, deriving quite a bit of benefit. And at the present time, the activity of what we know, we have some data with TROP2 ADCs in lung cancer in general. The activity is not felt at the present time to be that strong that it should be put ahead of the chemotherapy. Alimta is, pemetrexed is generally a well-tolerated drug and generally an effective drug in ALK patients. And at the present time, now it is possible as we do more work that it may be moved ahead. The other problem, so I just want to briefly mention, the reason this drug has generated buzz is that there are 2 other Daiichi drugs that are targeting different proteins. One is called trastuzumab deruxtecan, and it binds to HER2. HER2 is another protein that can be present on lung cancer cells. And that drug has shown very, very, very good activity. And then the other drug they have, right now it has a number, it is 1402, and it binds to something called as HER3. And the interesting thing is that the chemo that is attached to the trastuzumab deruxtecan and the 1402 is the same chemotherapy, the deruxtecan chemotherapy. And 1062, which is this drug.
I don't do HBO. I don't do Amazon.
Sorry.
So the 1062 has also the same chemotherapy called deruxtecan. And part of the reason this drug has generated excitement is that those drugs showed very significant benefit. But they are targeting different diseases. Whether we will see similar benefit with deruxtecan remains to be, with TROP2 remains to be seen. There are two other things to note about this based on the experience with trastuzumab deruxtecan and the 1402 is that some patients can have significant nausea and vomiting, a small minority, but can have significant nausea, vomiting. And it can get challenging to do more than 5-6 cycles. I'm not saying it is not possible. Whereas with now, it could also be because these patients have gone through so many different treatments that it gets harder for them to tolerate the drug. And if we move the drug earlier in the course, they may be able to tolerate. But I can tell you that with pemetrexed, we can sometimes go for year, 2 years in some patients, not all, I want to be very clear, but in some patients. So at the present time, it is very promising. But I don't know that I feel based on the data we have that I would move it before chemotherapy. And I think they're testing it in the right population. The final thing I want to mention is that this is being looked at in ALK patients, not because there's something specific about this that will work in ALK patients. TROP2 is something that is expressed in several lung cancers. So they are also looking at ROS1, BRAF, KRAS. So there are several other subtypes that are being used. There is not something unique to ALK about TROP2.
Got it. Thank you. Could you please describe the overall treatment plan for the patient from the patient's point of view? Does a patient in the trial take injections, infusions, pills? How frequently must they visit your lab?
So the treatment is once every 3 weeks. It's an infusion. And scans are done after every 2 sessions. Now, the study schedule is a little more involved because anytime you're in a study, you have to be seen a little more frequently. And initially, the evaluations are for, I think, 2 weeks, the day of the infusion, of course, and then 2 weeks after that, once a week. And then after the second infusion, another visit a week later. And then it is only with every infusion that you are assessed. There are fairly, what I would say, stringent eligibility criteria. You have to have tissue that needs to be submitted, and the tissue should have been collected within a certain period of time. I'm blanking out what the time limit is, particularly in this trial. So you could have had a biopsy 6-10 months ago, and you can submit that tissue. But you have to submit that tissue. They have to receive it and ensure that they can assess that tissue for the markers they want to assess at. And then you have to have what is called as measurable disease. One of the challenges I have is some of my patients have only bone metastases. And if you only have bone metastases, it may get very difficult to measure bone metastases. And so there are certain limitations, but most ALK patients should be eligible if this study is considered.
Do you know how much tumor material you need for the trial?
Generally 15 slides. So if you had a lymph node biopsy, a neck node biopsy, let's say, it should be good enough, or any core biopsy should be good enough to get the tissue material.
Or even a core biopsy, that's great.
Yeah.
Doesn't have to be a resection.
No,
that's
no,
really
no,
good to
core
know.
biopsy should be enough.
Should patients expect higher toxicities compared to platinum-based chemo?
That's an interesting question. There are different toxicities, let's say. In general, the drug is well tolerated, but there is some GI symptoms, nausea, heartburn, occasionally diarrhea. But it's mild, it's manageable, it's more of an irritation. Platinum-based chemotherapy in some patients can cause significant side effects, but usually in patients, what we do is we do only 2 to 4 cycles of platinum-based chemotherapy, and then we maintain the patient on Alimta. And the Alimta alone portion generally is quite well tolerated. And I would say at the present time, I would even go to the extent of saying that single agent Alimta may be better tolerated than these drugs. Now, I have to be careful in that saying that, because these drugs were administered after patients had received multiple different treatments. And so those patients may have experienced a high level of toxicity. If we move those drugs earlier in the course, maybe the drugs may not cause as much toxicity. But my sense today is ALKtALK may be better tolerated than these drugs.
Got it. This is a big one. Is the TROP2 ADC brain penetrant? Or if not, how would patients with brain metastases be managed on the trial?
So that is the biggest, I shouldn't say biggest, but that is one of the concerns. In general, the monoclonal antibodies, the figure I'm showing you here, are fairly large molecules that they may not be able to get through the blood-brain barrier. And so they may not be able to address. Now, we don't have good data to confirm that, but they may not be able to address brain metastases. And in that situation, we may have to go to radiation or like SRS or use a local treatment. My suspicion is that once they have enrolled a certain number of patients, they've seen a certain number of benefit, that they may, the next trial or the next cohort they may enroll is doing the ADC with an ALK inhibitor, hoping that the ALK inhibitor may control, but that's just pure speculation on my part. I will just say that on the chart, TROP2 and TROP5, no, TROP2 and TROP5 are not the same. And as of now, the Ommaya reservoirs have not been used to deliver an ADC. The only ADC in this class that is approved there are several ADCs that are approved, but in this class that are approved is trastuzumab deruxtecan. And as of now, as best as I know, it has not been administered to a Ommaya reservoir, but that's a very good question. My suspicion is as we gain more experience that they may do such a trial.
The trial is designed for 150 patients and includes all the mutation-driven cancers, EGFR, ALK, ROS1, MET, etc. Is there a set number given to each subset, or is it first come, first serve?
It's first come, first served, though the idea is that they at least enroll 20 patients in each cohort.
Do we know how many patients have been enrolled so far?
No, I don't. What I can tell you is that the EGFR cohort is closing or just closed. So they have already enrolled the EGFR cohort.
And when did the phase 2 trial start accruing? And if the results are good, when would you anticipate phase 3 starting?
The study started in January of this year for this particular study. My suspicion is we won't have data till probably early 2023. They may plan a phase 3 study as early as late 2022, once they have the signal. My suspicion is that a phase 3 study won't start till early 2023. However, what I can say is that FDA these days, and that's why they are doing it after chemotherapy, because that's an unmet need. Right now, there is no standard of care after chemotherapy in such patients. And so if the data looks promising, the FDA may give, just based on this study, an accelerated approval. We may not need to wait for the phase 3, but it will all depend upon how good the data is.
The phase 1 trial included 34 oncogene-driven patients, 3 of whom were ALK positive, and overall response rate across all doses was 35%. Median duration of response was 9.5 months. Can you speak to these results?
So 35%, if it holds up, will be very promising. 35 to 40% is felt to be the response rate of platinum-based chemotherapy. My suspicion is that there is a larger data set that suggests that overall response rate in lung cancer patients, this is not ALK patients, lung cancer patients, is 25%. And that's promising because these were patients, a good proportion of patients who had received chemotherapy, immunotherapy, targeted therapy, and then received that. And 25% response rate is very promising. But we just need more data before we can be certain of that. There was another question on the chat. In this trial, the DS-1062 is being given as single agent. It is not being combined. But I suspect that combination trials will be initiated once they've generated some data regarding the drug.
Do we know in the phase 1 data how the ALK patients did? How many there were?
No, not that I'm aware of.
Okay. Do you think that ADCs, particularly this one, could be safely combined with other ADCs and or ALK TKIs?
My hope is that we can combine it with ALK TKIs, that or other targeted therapies. That is the promise. So this is going to be the first step. Then subsequently, I really strongly suspect that they will combine it. My suspicion is not necessarily this ADC, but other ADCs. There are already studies being planned to combine with the EGFR inhibitors because it's a little slightly ahead. And the reason it is ahead, not because we don't want to take care of ALK patients. Those patients don't do as well as ALK patients. And so those studies accrue faster than ALK studies. And so those studies are already being planned. So I'm certain that it will be done with ALK as well.
Do the early results of this ADC show that ALK patients or oncogene-driven patients do better than non-oncogene-driven patients?
No, we don't know that. The
Okay.
only reason that they are testing is because these are now defined cohorts. And if they can show activity in these defined cohorts, then you can get FDA approval. So if somebody doesn't have a driver oncogene, then it's a sort of a little more nebulous cohort. So it's difficult to get that approved. But in each of these codes, it's much easier to approve. That's why they're testing it. As best as I know, there's no difference in TROP2 expression between oncogene lung cancers and non-oncogene lung cancers.
Okay. For someone with ALK who has exhausted TKIs and chemo, what might make this trial advantageous over other trials? For example, TILs, novel immunotherapies, SHP2, PARP inhibitors, etc.
I don't know if I can say one is better than the other. I will say this. Excuse me. If there was an opportunity, especially if somebody has been on an ALK inhibitor for some time, this is an educated guess, and others may disagree. So I want to preface by saying that if somebody has been on an ALK inhibitor and has done well for a period of time, I'd rather go for something that is adding something else to the ALK inhibitor before I go to an ADC trial, because there may be a potential that if you got the right combination that you may do well. If on your last ALK drug, you were not on it for too long a period, then it may be better to go to ADC. Now, if you went to ADC because that was accessible, that you were eligible, it won't be wrong. I'm just saying that in general, you cannot compare one trial to the other. The fact that they're a trial means it's experimental, we don't know. But in general, I would say if somebody has been on an ALK drug for a long time and then they are progressing, it may be better to go on a combination. I just want to mention, this is the TIL story. This is one of the TIL trials that I wanted to show. And what happens is, what TILs are, is there you do have to resect a portion of your tumor. And what they do then is they will isolate lymphocytes, the patient's lymphocytes that have infiltrated the tumor. They will extract that. So you resect the tumor and ship it to the company. The company processes that tissue they receive. They remove the lymphocytes that had already infiltrated the tumor, expecting that those lymphocytes have some capability to attack the tumor but are being blocked. Then they grow those lymphocytes in the lab. They sort of juice them up with certain chemicals that will make them stronger. And then they are sent back to the center, and then those patients' own lymphocytes that have been juiced up are infused. There are some drugs that the patient gets to create a space, as one can say, for those lymphocytes to come in. And the hope is those juiced up lymphocytes, patient's own lymphocytes, can then attack the cancer. So that is TIL. And if you could indulge me, I don't know if this is, I just wanted to finish up by this case, and I will be happy to answer this question. So this is a patient of mine, and she is on the call today. And I said, I hope I'm not embarrassing her. She was diagnosed in October of 2011. And to me, it is so remarkable because in August 11th of 2011, CRizzotnib was approved. And she was also on something like 2 or 3 liters of oxygen. She walked in to a colleague of mine who first evaluated her. She got started on CRizzotnib, and the scan next to it is the scan from April. She immediately improved. But in late 2013, she started having progression. And in March of 2014, she started on ALKtALK. And she has been on ALKtALK since March of 2014. So almost now coming up to 8 years. Now, more recent scans do show a tiny bit of progression. I don't know how well you can see the lung spots. But I cannot describe what it means to know that a patient has survived with stage 4 lung cancer for 10 years. But more importantly, what she told me, and she told me this very recently, and it has made such an impact on me, that she picked up quilting just about 6 years ago after she was diagnosed with lung cancer. And I just can't describe what it means to be a lung cancer doctor for 21 years. And then to see these pictures of quilts made by a patient who had stage 4 lung cancer for 10 years, who did not quilt before she was diagnosed with lung cancer, but with the advances that have occurred and with the treatments that are available, she has picked up and done such a phenomenal job of quilting. And so that's my story of hope. And that's
Dr.
what this is all
Gadgeel.
about. Yes.
Dr. Gadgeel, you didn't show the picture of me fishing.
I didn't show the picture of fishing. I just wanted to show the quilts because the
I'm
quilts
just
made
kidding.
a bigger impact on me.
They were they're art therapy
therapy.
for me, honestly, art therapy.
And thank you for sharing this with me. So we don't have everybody do as well, I want to be honest, but a lot more patients are doing as well as Ms. Wren, she disclosed herself, is doing. And I sincerely hope that we continue to improve the outcomes of ALK patients. So thank you. That was my last slide. And I know I went too long. I apologize, but I'm happy to stay on if you have any further questions.
If you could stop sharing your screen, then we can see
I know,
the
I
chat
will,
better.
I will. Sorry, hold on.
All right, it's okay.
Uh,
I thought you were gonna like have me as your subject.
I know, I'm sorry.
I'm too
sorry.
complicated.
I'm sorry. You have to send me some quilt pictures.
I will. I took up basket weaving, but I
Okay,
won't share you
good. Then
those.
send me those pictures.
All right. So let's get to some of these chat questions, and you can read them along. So if you want to read them, Dr. Gadgeel, you can answer them.
Okay, so so we talked about the single drug. It is a single drug style, and our patient has exhausted TKIs and chemos, and had a expression of ALK and T53. Is TROP2 trial good? Yes, that particular patient, the TROP2 trial will be good. Right now, there is no limitation on the number of prior treatments. Some trials, one of the problems is that you can't have received more than a certain number of trial treatments. What do you think would be a solution to avoid progression? Yeah, that is where the whole research is. I don't know if I have a good answer right now. And I sincerely hope after giving that hopeful story, this doesn't come out negative. But at the present time, sometimes it feels like you start on a drug and you expect that at some point the patient is going to progress, and you're just sort of waiting for that progression. And so we want to definitely get ahead of the game. But there's a lot of work that needs to be done, and we just hope that we can identify features of the cancer that will tell us that, okay, this patient is not going to do well just on an ALK inhibitor, and we need something else. And what else that is going to be is also something we still don't know.
Most of them are thank
what a great
yous.
story. Thank you. Thank you, Miss Hura. Yeah, this is, first of all, I want to thank you folks. Creating this group is amazing. I cannot tell you how much, every time I talk to a patient of mine, how much sense of strength they derive from, from being involved with such a group. And we learn such a lot. I can tell you that patients have told me about things that you folks are trying, and you exchange your experiences. And I've been very open to, working with the patient to try those options. I think this is an extremely smart group, and I mean that sincerely. And what you are trying, please share with us. We can learn from you folks. And I think that we hope we have more such groups in lung cancer. One of the problems, as you folks know very well, is lung cancer doesn't have a good reputation because everybody automatically assumes the patient is a smoker. Even if they're a smoker, I can tell you that only 15 to 20% of smokers develop lung cancer. I'm not suggesting people should, smoking is not good and people should not be smoking. But everybody knows about George Burns. I think he died with a cigar in his mouth. There are patients, we don't know exactly why even the smokers develop. And this cancer should not have the, if I can say, stigma that it has. And it is groups like you that can help get rid of it. And it doesn't get the attention I think it deserves. And I'm not trying to say one cancer deserves more attention than the other, but I do feel lung cancer needs to get more attention.
I want to thank you for coming in on a Sunday and being the doctor that you are and the person that you are. And we're all so fortunate to have you as our doctor. Jeff, I don't know if you have any follow-up comments or just sentiments of some sort.
A heartfelt thank you from myself and all of the people on the clinical trials committee. So the questions that you were asked came from Ray Hall, Ellie Urban, Julie Silberger, and Colin Barton, and myself, just so everyone knows who their team members are. Thank you, sir. I hope to meet you.
Thank you very much. And I just want to say hi to my patients. I cannot tell you how great it is to see all of you. So, and thank you to, and also seeing all of you. So thank you very much. It was,
Thank
I
you.
had fun.
You guys can unmute and talk away and thank
you.
Dr.
Thank
Gadgeel.
you.
Thank you.
Thanks.
Thank you.
Thank you. Thank you much. Good to see your face.
Thank you.
Bye.
you very much.
Thank you.
Hey, Francine. All right. Thank you, Dr. Gadgeel. I'll see you
Thank
February
you.
1st.
Thank you.
Yes,
Thank you.
thank you guys. Thank you very much.
Bye.